to all the panelists and moderators, also to all the participants. Assalamualaikum warahmatullahi wabarakatuh. Selamat malam untuk semua dokter-dokter yang saya hormati. Welcome to the 4th Asia Pacific Ophthalmic Trauma Society webinar in conjunction with JEC Ophthalmic Trauma Service with the title of Overcoming the Challenges in Ophthalmic Trauma. We would also like to welcome and send our biggest gratitude to our honorable panelists and moderators from all over the world. From India to Nepal, to Pakistan, to Malaysia, to Singapore, Taiwan, Australia, and United States of America. Thank you for all of your support and enthusiasm. Special acknowledgement to our sponsor tonight, to Chendo Pharmaceutical, for making this possible. Before we jump into the main program, I would like to invite Dr. Yunia Irawati as the head of Ophthalmic Trauma Service in JEC Eye Hospitals and Clinics to give her welcoming notes. To Dr. Ira, please, the time.
Thank you, Dr. Alia. Welcome, everyone. First, I would like to say thank you for all participants who have joined with us in the 4th APOTS webinar in conjunction with Jakarta Eye Center Ophthalmic Trauma Service. More than 1,700 participants from all over the region had registered to join with our webinar, and incredibly grateful for the enthusiasm. Thank you for the Jakarta Eye Center team to making this webinar possible. Special thank you for the President of APOTS, Professor Natarajan, and APOTS Scientific Committee, Dr. Gangadhara Sundar, and Professor Caroline Chi as one of board APOTS for the collaboration. I would also like to send my best appreciation to our international panelists and moderator from 9 countries: India, Nepal, Pakistan, Malaysia, Singapore, Thailand, Australia, USA, and of course our colleague in Jakarta Eye Center. The webinar today will mainly focus on the case-based discussion for challenging trauma cases. Hence, the topic of overcoming the challenges in ophthalmic trauma. Each panelist will share the unique cases and their expert in managing various trauma cases. Hopefully, this case-based approach will be a good way to share the current update in ophthalmic trauma management, while also keeping a good connection between the trauma society all over the world. And on behalf of everyone involved in this webinar, I hope you can enjoy this meeting. Thank you very much for your kind attention. Please, Dr. Alia, you can.
Thank you, Dr. Yunia, for the warm welcoming notes. So we would also like to invite Professor Natarajan as the president of the Asia Pacific Ophthalmic Trauma Society to give a word or two before the start of the session. Professor Natarajan is the vitreoretinal surgeon from the Aditya Jat Hospital, Mumbai, India. Please, Professor Natarajan, the time is yours.
Good evening all. Welcome to the 4th Asia Pacific Ophthalmic Trauma Society webinar, where we are having a session by the Jakarta Eye Center. I'm glad in February this year I inaugurated the Jakarta Eye Center trauma session. I'm happy Dr. Yunia, Dr. Gita, Dr. Johan, Dr. Nano, and Dr. Gangadhara Sundar and Rupesh Agarwal put up an excellent program, and wish everybody great learning. Thank you.
Okay, thank you, Professor Natarajan. Before we move on to the first session, I would like to show you the rundown of this webinar. Basically, this webinar will be divided into 6 distinctive sessions. Each will specifically discuss about different aspects of ophthalmic trauma and will be moderated by the experts on each field. So here's the rundown, and without further delay, I'd like to invite Dr. Gangadhara Sundar as the moderator for the first session, eyelid and orbital trauma. Dr. Ganga is an orbit and oculofacial surgery surgeon, from the National University Hospital, Singapore. Dr. Ganga, please, the session is yours.
Thank you, Dr. Alia, Dr. Yunia, and Dr. Gita. It's my pleasure to introduce three wonderful oculoplastic surgeons from this part of the world. Dr. Harnavita, the head of oculoplastics, followed by Dr. Rohit Saiju from Nepal, and Dr. Yunia, who's going to share a pole-to-pole case. And finally, to top it off, we have an expert speaker from Denver, Colorado, Professor Prem Subramaniam, who will teach us how to manage one of the challenging aspects of orbital trauma. Over to you, Dr. Harnavita, to share us something about eyelid lacerations.
Thank you, Dr. Ganga. Good evening to all panelists and all moderators and participants who joined this meeting. Thank you for your join with my webinar tonight. Okay, I would like to share my experience how to manage eyelid occlusion with canalicular laceration. My case report, boy, 4 years old, came to JEC hospital with chief complaint, bleeding from the right eye after hooked to a nail on the wall 2 hours before admission. 2 hours before admission, the patient was playing around, jumped, and his eyelid accidentally hooked to a nail on the wall. He was brought to Jakarta Eye Center Hospital directly. And the ophthalmical status, there was full thickness inferior eyelid rupture with canalicular laceration, and the other part was normal. And the left eye within normal limit. And diagnosis of this patient, eyelid occlusion with canalicular laceration of the right eye. I plan to do repair the eyelid occlusion and canalicular laceration with monocular silicone intubation of the right eye in general anesthesia. This is my video. The first, I irrigated with saline from the clotting and debris in the wound. And then I try to find laceration of the canalicular with Bowman probe. After I identified the canalicular laceration, and then I insert the silicone tube with stent through the punctum. So after that, I remove the stent, and then for intubation to the medial cut of laceration, I postpone because I plan to do the suture of the conjunctiva first. Yeah. I suture the conjunctiva with interrupted suture with buried knot because to prevent the irritation to the eyeball. After finish the conjunctiva suturing, I insert the silicone tube through the medial cut of the canalicular laceration into the lacrimal sac until we cannot insert. Sorry. Sorry, I problem with my video, and then I insert the silicone tube to the lacrimal sac. How much I have to insert the silicone until we cannot insert the silicone anymore. After that, I suture the periocular tissue around the canalicular laceration. I use the Vicryl 7O to suture the periocular canalicular tissue. I suture until all of the tissue cover of the silicone tube. After that, I suture the orbicularis muscle around the canalicular rupture of canalicular rupture. We use the same Vicryl 702.
Another 30 seconds, Dr. Hanavita.
Yeah, okay. And then after that, I stitch the orbicular muscle. I start from the lateral to the medial. We use the Vicryl 602.
Sorry, that's the 5-minute warning here.
Okay. And then the last, I stitch the skin.
Would you like to conclude with your learning points?
Yeah. Okay. Finally, I suture the margin of the eyelid. And then I fixated the silicone tube to the skin and to orbicularis, like this. This is the result. Post-operation, I give the patient with antibiotics 3 times orally and anti-inflammation 3 times a day orally and antibiotic eye ointment for the wound. And then suture removal 2 weeks after surgery and silicone removal 3 months after surgery. This is the result of the patient 3 months after surgery. And then this is 1 year after surgery. Thank you.
Thank you, Dr. Hanavita, for sharing a common problem, but how a combination of good surgical technique and a good experienced surgeon delivers great results. While Dr. Rohit uploads his presentation and shares the screen, Dr. Hanavita also shared the point that most childhood accidents are from domestic accidents. So it just happens in your neighborhood, inside your house with toys, nails, doorknobs, so on and so forth, and how education prevention is more important than cure. Great video, Dr. Hanavita. Is Dr. Rohit Saiju ready to upload his slides? And she also highlighted the value of how the technique intraoperatively identifies a cut end of the canalicus for either monocanalicular or bicanalicular intubation. If you can't find the canalicus, Dr. Hanavita, how would you do it? Rohit, please upload your slide.
I think Dr. Rohit not in here yet, Dr. Ganga.
Would you like to proceed, Yunia, with your case then?
Yes, I think I'll do the presentation, the next, Dr. Ganga.
Yes, please, if you don't mind. Yeah, thank you. We can answer these questions towards the end. Thank you.
Okay, thank you, Dr. Ganga. Now I would like to present about the multiple approach in managing a complex blunt trauma. Slide, please. Slide, please. Yeah, I have a patient, 45 years old man suffering a blunt trauma of his eye. And when the wound block is suddenly hit into the face while he was working, and the eyelid laceration of the left upper eyelid and lower eyelid is present, accompanied by decreased visual acuity, he was treated with the initial eyelid repair. And then the patient usually come to us 3 days after the surgery. After the accident. When we do the examination, we can see the visual acuity is light perception, the normal intraocular pressure, There is a multiple proline suture at the superior and inferior eyelid, also the medial canthal region. And we saw there is a subconjunctival hemorrhage, and then there is a hyphema at the anterior chamber. The lens was cataract, and the fundus could do the examen very well. And slide. Yeah, this is the USG examination. We can see there is a retinal detachment. And this is the orbital CT scan. We can see in here, there is a multiple fracture, usually in the nasal, at the naso-ethmoidal fracture, grade 1. Yeah, and we can see there is in here from the CT scan also. Slide. And we assess the patient with full thickness upper and lower rupture with the canalicular involvement, and at the medial canthal rupture left eye. There is a naso-orbital ethmoidal fracture, nasal fracture, and the septum deviation. There is a hyphema, traumatic cataract, vitreous hemorrhage, and retinal detachment. We hospitalize this patient and do the complete blood workup, radiology screening for the COVID, and we plan to do the repair eyelid restoration with silicone tube, and then reconstruction for the medial wall, and canthal reconstruction. And our colleagues from the ENT do the septorhinoplasty, and our colleagues for the trauma surgeon did the TSV and emulsification and silicone oil. Slide. After the hyphema is resolved, I think Dr. Sandy will be continue the surgery in this patient. Please, Dr. Sandy. This is our surgery did by Dr. Sandy. Dr. Sandy.
Dr. Sandy, you're still unmuted.
Oh,
yeah. Okay, yeah. So I did the surgery, do the combinations of cataract extractions and vitrectomy to resolve the vitreous and then the retinal detachment. So this is the first step. There is a synechia in the anterior part, so I tried to do the visco dissection to release all the iris from the lens. After I release all the synechia, I do the phacoemulsification as usual. Do every steps in a normal way. We can see here behind the lens, we can see there's the fundus reflex a little bit low, and there is some vitreous hemorrhage over there. So I try to extract the cataract with the usual phacoemulsifications, and then I put the lens. So this is the part that I do the IA of the lens, and then yeah, you can see here in the posterior segment there is a little bit seen of the vitreous hemorrhage. So I put the lens in the back, and then because I will continue it to do the vitrectomy, I try to put one stitch to make the anterior chamber stable.
30 more seconds, Dr. Sandy.
Yeah. Okay. Yeah, so this is I did the vitrectomy. We can see here there's a little bit mild of vitreous hemorrhage, and maybe after, so I did try to clean all the hemorrhage from the vitreous cavity. Okay, after I try to finish all the blood from the vitreous cavity, maybe we can see here there is a shallow detachment actually in the superotemporal part. It's from 8 o'clock until 12 o'clock. Maybe this is the part that I still try to finish all the vitreous. I put the triamcinolone just to make sure that all the vitreous is already being gone. And we can see here that in the superotemporal, there is a little bit break or tear over there. And then I try to cleaned up all the vitreous that is remains still in the posterior part. Okay, and then I try to make signs with the endodeotomy for the break part, and then I do the fluid air exchange to take it out all the fluid from behind the break, and then maybe we can move forward a little bit. Fast forward. Yep, and then I do the 360 degrees of laser in all the retina, and then maybe this is the last part. I see that after that we can see there's a little bit intraocular choroidal detachment, and then I put the silicone oil. The reason is because there will be another procedure for these patients just to make the eye stable. Okay, next slide.
Okay, I think after Dr. Sandy did the operation, I did for the eyelid laceration, and the ENT doctor did the nasal for the septorinoplasty. First, I did identify the rupture. I look the suture is not proper, and then I lose the suture. I did with the probing to know if there is a laceration at the superior canalicular. But in the inferior eyelid, when I insert the probing, and then I can see the posterior, I mean the proximal of my probe. And then after that, I make sure it with the elevate the periosteum surrounding the canalicular and the lacrimal sac to make sure it there is laceration in the inferior canalicular. But now I know there is no laceration at the inferior, only the avulsion of the medial canthal at the inferior, because I didn't show the proximal of the canalicular. And then I try to find the canaliculus proximally. Yeah, in here, using the microscope is very easy to find. And then I did the irrigation to make sure it the lacrimal sac. And after that, I suture the periosteum at the medial canthal to reposition first, and put the inserter of the tube from the inferior, and then from the superior canalicular, go to the communicans canalicular. And after the silicone probe is on the nasal, yeah, and then for the canalicular laceration, I suturing the medial canthal first. I using the Proline 3O, and then put the silicone, and I suture the eyelid margin. For the apposition, the full thickness eyelid margin at the superior. And then I suture all the wound, yeah, subcutaneous to proximately, and then the skin with the Proline 6O. After the surgery, the ENT doctor did the surgery for reconstructive the septorinoplasty.
Okay, sorry, the time?
Yeah, I think after this, yeah, Dr. Sandy will be explain about the end of the result. Dr. Sandy, please.
Yeah, in about 30 seconds, please.
Yeah, okay. Next slide, please.
With the questions for the experts, and Dr. Rohit is standing by to present next.
Yes.
And finally, we'll have the expert lecture by Professor Prem Subramaniam.
So, okay, I will faster. This is 1 week post-surgery. The retina was good. But the visual acuity is still 0.05. So I consulted neuro-ophthalmology divisions to find is there any problems from the divisions. Slide, Dr. Alia will present after this one.
Okay, so let me share my slide because apparently they don't have my current slide yet. So, sorry. Sorry. Yeah. Okay, so basically the patient came to my clinic with persistent decreased vision after the surgery. The consensual reflex of the fellow eye was decreased with good posterior segment. Unfortunately, other examinations such as visual field examination or other visual function testing could not be performed due to some barrier. So we still try to figure out whether this is a traumatic optic neuropathy cases or it was actually global retinal dysfunction due to traumatic retinal detachment. So we plan to perform further examination, but unable to do so because the patient never came back. So I think we will leave the question to the Dr. Prem's expertise afterwards. So yeah, that's the end of the case for this one.
Thank you for sharing the case. I think Dr. Rohit is standing by. But I assume your question for Professor Prem later on, who will address talk on traumatic optic neuropathy, while Dr. Rohit is uploading and sharing his screen is a very nice and very challenging case of a lid, lacrimal, orbital injury, globe injury. It's a closed globe injury, which had anterior segment and posterior segment features, and finally with poor outcome with the challenge of a traumatic optic neuropathy. That's actually completes the definition of ophthalmic trauma: intraocular, extraocular, adnexal, and facial. So Rohit, are you ready to share the slide?
Yes, hi everyone. Apologize not being in the schedule because of the interruption of electricity in my home. Here I am. I'm audible, Ganga?
Yes, you are. Go ahead, please.
Yeah, thank you very much. Good afternoon, good evening even, everyone. Especially I would like to be thankful to Dr. Yunia and Dr. Ganga, providing me a platform to share my knowledge in some of the challenging cases. So I will be going to present a Calvarian bone graph for the all orbital floor fracture cases. Myself is Rohit Saiju from Kathmandu. I do not have any financial disclosure to say. Here is a referral case of 27 years old male who sustained a road traffic accident 4 months ago and presented to me with about 7 millimeter of inophthalmos, diplopia at vertical gauge. And this patient came very lately to me because of the several incidents. He became the contact tracing person and stayed for quarantine for some time, then had meningitis and stayed in the hospital for another few weeks, and came only after 4 months of the incident. So in examination, he had vision of 6/6 in both eyes. In the right eye, there was a limitation of extraocular movement in all gazes in anterior segment, and fundus found normal in the right eye as well in left eye. In examination in Hertel by bar of 105 millimeter, about 7 millimeter of inophthalmos in the right, being the 17 millimeter in right eye and 34 millimeter in left eye. So here the panoramic view of the CT scan, you see the craniofacial fracture as a big depressed fracture of the frontal bone, as well as you see there is a impure type of the broad fracture with the orbital rim, and there's a big defect in the roof of the orbit, and the inferior orbital rim as well as middle wall has gone. In another CT, you can see there is a defect in the roof, and inferior floor of the orbit has depressed down quite. So we planned for surgery combinedly with the neurosurgeons and MaxFax surgeons team. And neurosurgeon provided us a very nice piece of calvarial bone. And the patient had inophthalmos of the remarkable 7 millimeter. That's why we decided to use autogenous calvareal bone as an implant for the blood fracture repair. So here the small videos showing that the approach to the blood fracture here, inferior fornix has exposed, and after gently cauterize the inferior fornicial tissue, gave the incision in the conjunctiva and underlying tissue along with the periosteum, and lifted the periosteum very nicely and approached to the fractured area. And we identify the extent of fracture posteriorly and sidewise as well. And then we fix up that calvareal bone piece nicely, making this convexity part superiorly, so it will augment the little bit volume in the orbit. So during the surgery, we found that there is a nice pulsatile proptosis. That is because of the superior roof of the orbit was defect, and this encephalocele is giving the pulsatile things. My neurosurgeons did a very nice job. The huge calvareal defect of the frontal bone was repaired by the bone cement, and plating was done very nicely. So this part has very nicely done. And this is the portion of the calvareal bone which is harvested from here, and we place very nicely, and it is clipped in the infraorbital rim, and which support the floor of the orbit. At the same time, it will augment the volume of the orbit. And after the surgery, there was about 4 millimeter of inner thalamus has corrected. Still, there is a small amount because, you know, this is a very old case, 4 or 5 months old. In comparison, the hypoglobus in the left preoperative eye, you see, has corrected very nicely, and about 4 millimeter of inner thalamus corrected. This is pretty satisfactory outcome looking at his previous preoperative features. And he has got little amount of limitation in the vertical gaze in extraocular movement, but in the horizontal gaze, there is no diplopia, only the diplopia in the extreme of gaze, which is professionally quite satisfactory. So what are the advantages of the calvareal bone graft? Calvareal bone graft is autogenous donor tissue. That's why it is very biocompatible and very much less chance of getting the extrusion and infection, and revascularization occur very nicely.
Okay, sorry.
And disadvantage is this. Yeah, can I have 1 minute more? Just to quick finish, summarize. And the disadvantage is that the harvesting part is very difficult. We have to do the second operation to harvest the things, and we oculoplastic surgeons are not very much expert in the things. I would like to acknowledge my colleagues, Dr. Amit, Alok, and Pranay, who was with me during this combined team for this boy. Thank you very much.
Thank you, Rohit. That was a great case, and you're showing that as an oculoplastic surgeon, you're not just dealing with the lid lacrimal orbit, but you're dealing with the face calvareal skeleton. And we practice reduce, reuse, and recycle. So we take body parts and reconstruct the face. It's my distinct honor to introduce Professor Prem Subramaniam. He's a renowned professor of orbital surgery, neuro-ophthalmology, an educator, an inspiration for all of us around the world, and an APOTS member, proud to say that. He's going to share with us his perspectives on traumatic optic neuropathy, what's new. Over to you, Professor Subramaniam.
All right, thank you very much. It's my real honor to speak to everyone today and to talk about what we have, where we are with traumatic optic neuropathy at this time, and what comes next. I have no relevant financial disclosures. A typical case, like you've already seen for someone who might have traumatic optic neuropathy, it'd be a 24-year-old driver driving at high speed on the highway, runs off the road. This driver was not restrained in any way, struck the forehead, and lost consciousness for 15 minutes. They were stable, awake and alert 2 hours later, and at that point, noted to have no light perception in the right eye, 6/6 vision in the left eye, an amerotic pupil in the right eye, so a large RAPD, and everything else was unremarkable. In particular, you can see the fundus looks normal, there's no optic disc hemorrhage, and of course, at this point in time, there's no pallor either. So this patient, of course, is interested in treatment. You as a physician want to treat, you suspect traumatic optic neuropathy. Are we going to give medicine? Are we going to do surgery, or are we simply going to observe? What helps us make those decisions, and where do these treatments even come from? Why do we use steroids? We use steroids because the classic model for optic nerve injury is neurologic injury, and specifically spinal cord injury. And in animal models where you have axonal crush or transection, the use of corticosteroids was shown potentially to be beneficial. In humans, medical surgical treatment is lacking. We don't have the same data, although for spinal cord injury we do. The North American Spinal Cord Injury Study, NACIS, suggested that megadose corticosteroid could improve outcomes in patients with spinal cord injury given quickly. And then the crush of an optic nerve done in animal models has been used to study optic neuropathy, but this is not how true traumatic optic neuropathy works. Real-life traumatic optic neuropathy is a complex shearing injury, force-directed injury to axons, vasculature, and supporting structures. So when we try to study this in animal models, we have to come up with something better, and I'll show you that at the end, some promising methods that we have to learn more about how to treat patients with traumatic optic neuropathy. As I mentioned, steroids were first tried over 30 years ago, and a number of non-randomized studies of traumatic optic neuropathy suggested it may be helpful, but in 2005, the use of corticosteroids in patients after head injury was demonstrated actually to be harmful, and we try to avoid using them now in a patient who has a concomitant head injury as well as traumatic optic neuropathy. Additionally, people have rediscovered the fact that Ken Steinsaper 20 years ago in an animal crush model demonstrated that the same megadose steroid that is given for those spinal cord injuries, when given to animals that have had their optic nerve crushed, actually results in a worse outcome than if you give those animals saline. The saline-treated animals did better than those treated with any dose of corticosteroids. So we need to be a little cautious in the use of corticosteroids. Indeed, one of the few prospective studies looking at steroids for traumatic optic neuropathy where they randomized patients to placebo or a treatment group and actually followed all of them. None were lost to follow-up. There's a trend, the dashed line, a trend towards improvement or better improvement with corticosteroids, but you can see there's a vast overlap between the two groups, and the conclusion was that steroid could not be defined as being better than placebo. So I'll mention one more medicine in a moment, but at this point in time, I don't use steroids for traumatic optic neuropathy. Do I do surgery? I've written a chapter here on the surgical management of patients with intra-sheath optic nerve hemorrhage and the utility of doing optic nerve sheath fenestration, but you have to have an experienced neuroradiologist to interpret the fact that there is intra-sheath hemorrhage and someone who knows what they're doing to drain this. In addition, and I think this applies to any kind of surgical intervention, it's critical that you can demonstrate to yourself that the abnormality is causing continued visual decline. And what I mean by that is if this patient came in with no light perception and a fractured optic canal, and you go in and decompress that canal, you do not know if it was the force of the injury that caused the vision to go to no light perception, or if it is the continued compression of the optic nerve that is causing that. On the other hand, if the patient is declining in front of your eyes, their vision is worsening, then doing a surgical intervention like this might make sense. There are many studies out there, case series really, that have been published primarily in the ENT literature, suggesting that endoscopic decompression of the optic canal is very effective, but I worry about those cases, those case series, because there is no control arm. And indeed, that is what is lacking in all of these studies, because if you look again at studies where they have a control arm, an observed arm, in addition to treatment arms, whether it's erythropoietin, whether it's steroid, when you include that control arm, you get results that are similar to the treated group. So I encourage any of you out there treating these patients, if you want to design a study, if you see, unfortunately, a lot of patients with traumatic optic neuropathy, do it in a way that will help us to learn more, because this is a problem that can occur more than once to patients. Unfortunately, patients, at least in North America, who engage in risky behaviors that put them at risk for traumatic optic neuropathy once might do it again. And in a series of 12 patients seen over 18 years, the majority of whom had corticosteroids for their first injury, and all of the 12 improved vision after their first injury. They then had a second traumatic optic neuropathy, and regardless of what was done, none of them improved. So we need to do something that is going to protect our patients from these traumas and from repetitive trauma and vision loss. So I'll finish by talking about two promising animal models that might help us to learn more and come up with better treatments. This animal model was developed using ultrasound. So applying ultrasound to the brow of an animal, the ultrasonic waves deliver shock and injury to the optic nerve. And here you can see a normal retina, or normal optic nerve, normal axons. You lose axons even in the contralateral eye, unfortunately, and you have a tremendous loss of axons in the treated eye. And you can see that here, that the problem with this model is that it actually damages the contralateral eye as well. So you don't have a good control, one side being injured and one side not. But this is a promising model, and with refinement, it will help us to understand better what is happening. Here, in a different model, the animal is actually impacted with a little hammer that hits at either 2 or 3 meters per second velocity and delivers a controlled injury to the brow, controlled force that is then transmitted to the optic nerve. And similar to the ultrasound model, you can see that controls, you have nice preservation of optic nerve function, but when you hit that animal with that plunger, with that hammer, the optic nerve is injured and the response of the retina and optic nerve diminishes as expected. So using these models may help us to use things like drugs, inhibitors of apoptosis, molecules like caspase-2 that may be involved in this whole process. And then finally, are there ways that we can bypass the entire optic nerve system, put cortical implants in to restore vision? This is also not a new idea. This is from the 1980s, that a patient was implanted with a cortical device that then allowed him to drive around in a parking lot. So I am hopeful that in the future we will have better treatments that we learn from the laboratory and take to our patients to help them recover from these devastating injuries. Thank you very much.
Thank you, Professor Subramanian. That is just fantastic, and I keep learning new things as we go along. Can I ask you one practical question? Can you have traumatic optic neuropathy without an obvious RAPD? And are we missing cases and only picking it up much later when we expose them to a second injury?
That's a very interesting point. We have learned that you can have subclinical optic neuropathy, and that perhaps by using other diagnostic means like OCT, we can pick up macular ganglion cell complex loss or other evidence of optic neuropathy that may fall below the threshold. The RAPD is a wonderful clinical tool, but as you suggested, it's not 100% sensitive. And for those people who could have sustained a minor trauma and then a bigger trauma, it would be very nice to know what their status is after the first insult.
Thank you very much. I think in the interest of time, I'll probably draw this session to a close, but just highlighting the fact that ophthalmic trauma, led lacrimal orbit, and finally, don't forget the optic nerve. And sometimes we end up thinking about the optic nerve in hindsight because it's behind the eyeball, but actually put that in the forefront and try to look for early signs of optic nerve injury along with other aspects of ophthalmic injury. Thank you very much for the great speakers. I hand you now over to Dr. Alia again for the next session. Dr. Alia.
Okay, thank you so much, Dr. Ganga. Thank you for summing up the very interesting first session that we have here. So we are now ready for the second session of this webinar, the anterior segment trauma. And for this session, I'd like to invite Dr. Johan Hutauruk from Indonesia and Dr. Mohan Rajan from India. Dr. Johan Hutauruk is currently the President Director of the JEC Eye Hospitals and Clinic. He is a renowned cornea and cataract refractive surgeon from Indonesia. And Dr. Mohan Rajan is an anterior and posterior segment trauma surgeon from Rajan Eye Care Hospital, India. So to both Dr. Johan and Prof. Mohan Rajan, please, the session is yours.
Thank you very much. So please, Mohan.
Yeah, thank you very much, Johan.
And let me thank the APOTS and the JEC for the joint organizing the joint webinar on ophthalmic trauma. It's always a pleasure to be here. And we have got a fantastic galaxy of speakers here on the anterior segment trauma. We've got a huge experience. Let me start off with the, can I have the first slide of the panelists? Yes. Speakers, the first speaker is Dr. Pusaribu, and he is a cornea, cataract, and refractive surgeon from the JEC Hospital, Jakarta Eye Center Hospitals, Indonesia, and he's got a huge experience in anterior segment trauma as well. Next one, please. Dr. Professor Jojono, and he's also from, yeah. Jojono.
Cahyono.
Jono.
Yes.
Jono, he's also from the Jakarta Eye Hospitals and Indonesia, and he's also a cornea, cataract, refractive surgeon. He's also got a huge experience in anterior segment trauma as well. And we go on to the next speaker, and he is LVSO. He is a vitreoretinal surgeon from Jakarta Eye Hospitals, Indonesia, and he did his fellowship from the USA as well. He's got huge experience in the posterior segment trauma. He's going to talk to us on severe blunt injury management from anterior to the posterior segment, part 2 as well. Next slide. Next slide, please. Yes, we have Dr. John Jested, and he's from the USA, and he's got a huge experience in anterior segment and cataract surgeries as well, and he's got also good experience with the trauma. And we're looking forward to his wonderful talk on Jested's fisherman's knot for the traumatic iris repair as well. And finally, I am be talking on traumatic subluxated cataracts, a very novel approach. I'll be showing 2 cases on that. Thank you very much for this opportunity. We'll go on to the first speaker.
Okay, Dr. Ucok, please share your screen with the surgical repair of corneal lacerations and anterior lens rupture.
Thank you, Dr. Johan, Dr. Mohan.
Thank you.
Let's prepare the screen, yeah. This one. Okay. Already show
yes.
Up? Okay. Okay. Good evening, everyone. In this lovely evening, I would like to share my case about surgical repair of corneal laceration and anterior lens capsule rupture. This is a case, a patient presented to our hospitals with 1-day history of penetrating injury while doing construction work. Fortunately, the trauma is not high speed and the damage is limited to the anterior segment of the eye. There is central corneal laceration and the anterior lens capsule has been ruptured. The posterior lens capsule is intact and there is no posterior segment trauma. No retained foreign bodies are found. There are 3 options for surgical repair for this case. First, close the corneal laceration and defer the cataract removal for later. Second, close the corneal laceration, remove the cataract, and leave the eye aphakic. Or the third, close the corneal laceration, remove the cataract, and place the IOL. And I choose the second one, close the corneal laceration and remove the cataract and leave the eye aphakic. This is my video case. First, I identify the wound, and we can see there is double layer in superior side of the cornea. And then I make incision and reform the anterior chamber and release the anterior synechia. The decision is after that, using 9/0 nylon suture, the corneal laceration is closed until it is mostly watertight. And place this suture at 90% depth without penetrating the cement membrane. And in this case, we have to make sure the corneal rupture is in a good apposition. After I close all the rupture with the nylon suture, I make this video faster, yeah. I put the dye intraocular into anterior chamber, and we see there is a little leakage in the scleral, and then I make a one stitch there. After that, I try to make a capsulorhexis. If possible, convert a small rupture of the anterior lens capsule into a capsulorhexis. But in this case, I use a cystotom to perform a can opener style capsular. Because a patient is young and the lens is soft, it can easily aspirate it using the manual irrigation aspiration and remove the entire lens, being carefully not to grab the capsule or cause a posterior capsule extension, and removing all the viscoelastic using the manual instrument. And the end of the surgery, I close the main port and fill the anterior chamber with air bubble.
Sorry to interrupt, Dr. Ucok, the 30-minute, the 30 seconds time.
30 seconds.
So, what we can learn from this case, first, surgical closure should be proceed in timely manner to decrease the risk of endophthalmitis, avoid tissue necrosis, and decrease patient discomfort. And the second, the goal of corneal suturing is to make the wound watertight to minimal scarring and reconstruction of the native non-astigmatism corneal contour. And the last one, the anterior capsule lens rupture is best treated by immediate extracapsular extraction. The lens matter should be irrigated out of the eye with a two-way cannula, hopefully preserving the posterior capsule. Thank you.
It's a very nice presentation, Professor Ucok, Professor Pasaribu. It is very nice. The only thing I would have done differently would have been because I do the corneal repair and the primary surgery itself. I remove the cataract and put a lens because I'll be able to put a lens in the back. But I want the opinion of Dr. Johan also on this particular thing. My co-moderator, whether you would have put a lens or you would have left the patient aphakic and done the secondary IOL implantation later.
Yes, based on the other eye, I usually, if there is no difficulties, I will put the lens in the back also. But maybe Dr. Ucok would like to see whether there is astigmatism, and then also we'll consider that after the surgery.
Yeah. Yeah, very nice presentation. We can take some questions maybe at the end of the session. We'll go on to the next speaker, Professor Yono. You can start, sir.
Thank you, Mr. Moderator. I would like to share my... Belum keluar deh.
Belum keluar?
Ya, sebentar.
Please share your screen, sir.
Yeah, one moment.
Yes.
Okay, can you see that?
Fine.
Yeah,
That's fine.
thank you. I would like to present these cases. This is a 33 years old man who has been beaten by some people one day earlier. He came with his very blurred vision and only hand movement, and the eye with in palpation is soft. There is a swollen of the eyelid. There is a subconjunctival hematome. Corneal edema was edema, and even though there is a deep anterior chamber with second 2+ flare, but there is a hyphema of 1 millimeter, and there is a vitreous in the anterior chamber, wide dilated fixed pupil, and superior iridodialysis and subluxated and traumatic cataract. The fellow eye was uneventful, and the diagnosis was blunt trauma with iridodialysis, hyphema, and everything. And in my opinion, if there is a blunt injury, we can have two direct forces. Well, one is the direct forces, which might be making the angle recession. There is a hyphema, and there is a retinal dialysis from the ora serrata. There is macular edema, might be, and choroidal rupture and scleral orbital floor. And the counter group forces might came to zonalisis, subluxated lenses, might be there is lens capsular rupture, iridodialysis, and pupillary sphincter rupture and vitreous prolapse. So the yellow one, I do think that it will be happen in this patient. So this is the first. The next day I will do the surgery is in just a local anesthesia. We put we starting with some subconjunctival silocaine, and then I make an incision of the superior side and the inferior. This is starting to do the iridodialysis repair for both sides. Yeah. Okay. Okay, we proved. So we repair first the iridodialysis, and we could see that actually the lens is also can see there is some rupture in the lens, and also we do the then I do things that we better to do just intracapsular cataract surgery, but there is some rupture again in the hair. Try to fix the vitreous prolapse, one thing, and then we clean up the anterior chamber. But I decide that just to leave it first as a phakic, because I do think that there is a vitreous hypophysi and retinal detachment. So just clean up everything, close, and then fill the anterior chamber with air bubble to separate all the strand to the cornea. Okay. So the next day we could see that the eye is still soft, hand movement, there's still some subconjunctival hematome, corneal edema, and white dilated. This is then it would be followed by my colleague, Dr. Elviosa, who is doing the vitreoretinal surgery. So, Dr. Elviosa, please.
Thank you very much, Professor Sir. And I think we'll go on to the second part. Elviosa will talk about the second part.
Okay. In the case of blunt trauma, retinal treatment is a complication that is quite common. This case is a blunt trauma due to hand blow, which begin with iridodialysis repair and traumatic cataract. We can see that there is a retinal detachment that is quite extensive in almost all quadrants. The procedure was started with a core vitrectomy, and then a PVD induction was performed, then proceed with a peripheral vitrectomy as clean as possible. After the vitreous is clean, subretinal fluid is slowly removed until the retina looks flatter. And after a flat retina is appeared, that's on the nasal side, there is retinal dialysis for 3 o'clock hour. Subretinal fluid residual were evaluated and removed. And after the retina is completely flat, an endolaser is performed on the dialysis area and the entire peripheral retina. After the laser, it was confirmed that there was no fluid in the subretinal area and a tamponade of silicone oil was given. And the sclerotomy wound is sutured to ensure there are no leaks and operation done. After 3 months of the retinal treatment operation, at this time, an evacuation and pupilloplasty will be carried out as well as secondary implantation. After the silicone oil is removed from the vitreous cavity, the structure of the retina was evaluated. The retina is attached, but there is a membrane on the superior arcade and nasal side. Membrane peeling was performed to prevent further complication. And after the membrane has been successfully removed, the laser is performed on the wound area and the entire periphery of the retina to prepare for the traction. And after confirming that entire retina is attached and laser, the procedure is followed by pupilloplasty and secondary implant and tamponade is given. And continue by Prof. Cahyono.
Ya, tutup dulu. Tutup.
Thank you very much.
I started with the, this is the second surgery. We do after the Dr. Elviosa pull out the silicone oil, we starting to have a scleral incision. And then first I have to do I make the second port for the secondary plan and starting to do the pupilloplasty just using just directly like this. Okay. Yeah, it is important to have a fluid from the posterior that we making the eyeball is still in pressure, because otherwise if it is become too soft, it is become more difficult to do. Okay, we try to make the pupilloplasty first, making smaller. Okay, the bottom one and then the superior part, because there is a sphincter rupture, and after the condition become the iris actually become firm and there's no contraction. Okay. Starting to implanting the iris glow lens. See, put it in the position and trying to still closing the pupil in the superior part. Iris suturing. Okay. Okay. Now I start to implanting in the retropupillary, starting from the nasal side. To me, it is more easier to have a retropupillary because this is firm and then it is just pressing the lid, the iris. So now the iris is, the pupil is already down there. We put again, start closing the bottom gap. Okay. Okay, closing all these things. Okay. At the end, we could see that that is actually then the day one is still about self-eye, but the visual activity is already increasing, and we give you levofloxacin and predforte hourly and methylprednisolone. And 2 weeks after that, we could see that the vision best corrected is 0.4. The retinometric reading is only 0.5. The IOP back to 14 millimeter, and giving endomethacin eye drops. And the take-home message is that in severe eye injury may potentially lead to a blindness condition, which will be ruin the future life of the patient. So prompt and integrated surgical intervention is mandatory to prevent further complication and blindness rehabilitation. Thank you for your kind attention.
Thank you, Prof.
Thank you.
And Dr. Uchok for the very wonderful presentations. I think for the interest of time, we should move on. Please, move on.
Next speaker.
Yes. Professor John Yastad is from Ophthalmology University of Missouri, and we'll talk about fisherman's knot for iris repair. Please, John.
You're unmute.
You're still unmute, John.
Unmute. Okay. Can you hear me there?
Yeah.
Yeah.
Okay. So the original mechanical suture was developed in 1976, and then Dr. Siepser modified that in 2005. And when I visited Indonesia, I developed a modification of that type of suture, which we just heard about the importance of that and saw a good example of suturing the iris. And this is can be used for either closing iris traumatic defects or to do pupillary cerclage to narrow a traumatically dilated pupil. So basically, 2 incisions are made on either side, perhaps a clock hour farther from where you would like to close the defect. You place a tenoproline or Gore-Tex needle through the iris, out the other side, and then reach in with a Sinskey hook or Kugelin hook, grab a loop of the suture, and then twist it 5 times, and then you just pull the needle back through. And we developed this because the Siepser knot kept untying when we were trying that on another case. So this is based on what's called the fisherman's knot, and that's used in sport fishing to hold hooks, and it will hold a 20-kilogram fish easily. We make 5 loops in the suture, and then if this is the needle end, we pass this needle back through the loop. And so it's easy to remember to do this. Let's see, there we go. Let me get that to go. Okay, so we developed our technique, and I'm just going to show an example of that.
This is Dr. John Jarstead, Associate Professor of Ophthalmology at the University of Missouri, demonstrating the fisherman's knot for iris repair. This is an enlarged model to simulate suturing of the iris with the fisherman's knot. We pass our needle through the iris defect, reach in with a Sinskey hook or iris hook, and withdraw a loop of suture. The loop is twisted 5 times, and the needle is passed through the loop of the suture. This is then pulled securely and gently with each end, securing the fisherman's knot. We always leave a locking throw behind, so we reach in and withdraw another loop of suture, twist this twice, and then pass the tenoproline needle through the loop one last time. Both ends are pulled gently to secure the fisherman's knot, and it creates a very strong knot that will not untie. and it's easy to remember. We'll now demonstrate the fisherman's knot in an actual patient who had floppy iris syndrome and an iris defect. Here we are suturing the two sides of the iris and docking the needle with a 25 gauge needle. The suture is then withdrawn, and a Sinskey hook is used to pull a loop of suture out of the eye. This loop is then twisted 5 times with some tying forceps, and the needle is then passed through the loop of suture. Both ends of the suture are then carefully secured to complete the fisherman.
And this is an example of a patient in Indonesia that we found with a congenital coloboma, and we were able to suture that with the fisherman's knot. That's actually the case that we discovered the fisherman's knot was useful in. So a few pearls in conclusion for iris suture repair. Sometimes perfect can be the enemy of very good if you try too hard. And be prepared and ready to start before you take on a case like this. I would always recommend either a retrovulvar or preferably a general anesthetic, because any sudden patient movement can be a disaster in these cases. So be quick, get in and get out, stop the anticoagulants for 1 week. And sometimes what they have is better than what they could end up with. So thank you very much for your kind invitation and an outstanding symposium. I'm honored to participate.
Thank you, John. This is very simple and easy to remember. I would like to ask, why is it should be 5 times, not 3 times? Have you tried the 3 times loop?
Yeah, that's a good question. I've seen some untie with less than 5, and you can actually avoid the second knot if you do 5 times. But I like to put the second back throw twice just to really create a lock, so it's never untied.
I do 4 times. Single pass 4 through.
4 and 2.
I have 4 times I do.
Okay.
Yeah.
4 knots. 4 knots. I'll
And
show you.
by the second one, 2. Another 2 for the second throw.
Yeah. Yes.
4. Okay.
So also in answer to your question, sometimes when you twist the loop, you're not sure if you've got it, 3, 4, or 5 times. But if you try 5 times, then if it unwinds once or twice, you still have enough. That's the main reason.
Easier to remember than the sipsers.
Yeah. I've seen the sipser untie with the second throw.
Yeah.
So that's what happened. That's why we discovered this, because Dr. Nicholson said, it's an emergency. I can't tie a sipser knot. And he says, I forgot how. And so I remembered from fishing, my career as a fisherman, the fisherman's knot is the strongest knot we use for putting hooks on.
Thank you. So please, Mohan, for the
Thank you very much, sir. Shall I share my screen?
Yes.
Are you able to see my screen?
Yes.
Yes, sir. Thank you very much for the APOTS as well as for the JEC. Let me thank Dr. Elia, Dr. Yunia, and Dr. Geeta for the wonderful coordination, and it's always a pleasure to be here. These are my financial interests, which is nothing to do with my short CV. I'm going to show you 2 cases of subluxated cataracts. The case 1 is it's a very hard cataract, and my anatomy professor, one-eyed patient, because other eye is ambulopic, traumatic subluxated. The shuttlecock injuries is probably the worst in my opinion as far as the cataract is concerned, as the anterior segment is concerned. You can see that I'm doing a rhexis, and can see that inferiorly there is a 3 to 4 clock hours of zonular dialysis there as well. This is a fairly hard cataract, grade 4 to grade 5 as well. So immediately for the circumferential stability, I put the CTR and go ahead and with the phacoemulsification. I always use a Venturi system like a Stellaris for this thing. And once I find that I was able to do the chopping, I found that the lens was wobbling around. So for the anterior posterior stability, I brought in the iris hooks for the capsular stability as well. So I went ahead with the phacoemulsification, making sure that the corneal endothelium is well protected by means of a very good dispersive viscoelastic like Viscoat, and making sure that reduce the parameters in the last piece, and injecting viscoelastic when you come out of the eye, because this is very, very important because the bag is a little loose there. And I always use coaxial irrigation aspiration. And when you have a CTR, it's always very difficult to, because it traps the cortex as well. It's always very difficult to remove the cortex. Always you have to go circumferentially along the equator instead of going radially. You can see this, the upper left one, the iris hook cut through the capsulorhexis margin, and the tear went across into the posterior capsule, and there was a vitreous loss as well. So I did the anterior vitrectomy through the main port as well, and I put a multi-piece lens. As I told you, the patient had traumatic mydriasis as well. I put a multi-piece lens into the, like an MA60 lens into the sulcus. You can see there is a tear on the posterior capsule, but the anterior, the capsule, the rest of the capsule was intact. The capsulorhexis margin was also there. And I put the tricot and preservative-free tricot to identify the vitreous. You can go through the limbus, but what I have done is I've gone through the pars plana, because this is a technique which has been advocated by Abhay Vaswada. I put a trocar and cannula measuring about 3.5 millimeters from the limbus and go behind. So always it's important that we remove the vitreous from behind, not from the front, because that reduces the traction on the macula, traction on the vitreous base as well. This animation shows very well. Abhay Vaswada from Ahmedabad has described this technique very nicely, wherein we can go through the pars plana and remove the vitreous from the from behind without producing any traction, and always making sure that the vitreous is also removed. So this is the final picture. You can see that I removed the vitreous. I'm doing the pars plana vitrectomy with an anterior chamber maintainer there, removing the cortex as well. And the lens is quite stable in the sulcus also. And the traumatic mydriasis, I tried to reduce the pupil size by doing a pupilloplasty. Unfortunately, I was not very, very successful, because this is a trauma which is almost more than 30 years old. He had an injury about 30 years back with a shuttlecock, and he was very scared of doing the surgery because he was one-eyed. So always I close all the ports with sutures whenever I have a vitreous loss. And this is just to show you that the patient vision improved about 6-9 parts, and with a 3-year post-op. The case 2 is I'm going to show you is a 20-year-old girl with a blunt injury with a stone, 170-degree zonal damage, traumatic mydriasis, traumatic cataract, small hydrodialysis, infranasally, macular scar, preoperative vision was 2/60. I always use the femtocataract in these situations, the catalyst, because it makes life easy for us. You can see here, the capsulorhexis is already done, the segmentation is already done. You can see the inferiorly, there is a zonular weakness. It's not actually a zonular dialysis, it's a traumatic cataract. It's a non-progressive type of disease. You can see the hydrodialysis also. Being a young patient, the cataract was relatively very soft, and went ahead and did a capsule and the cortical cleanup as well, injecting viscoelastic every time I come out of the eye, and putting a CTR and stabilizing the bag at that point, and then went ahead with putting a single piece hydrophobic acrylic lens into the bag, and the lens was very stable. Now, what do you do for the traumatic mydriasis? The patient was having a lot of glare also, and as a young patient, I don't want to do, and also I want to do something for the hydrodialysis as well. So I did what is called a single pass 4-throw pupilloplasty, which has been described by Professor Amar Agarwal of India. You can see here I'm doing a 10-0 nylon needle and doing a paracentesis, and I'm doing a railroading technique. I'm taking the 2 loops outside and passing it 4 times. This is the single pass 4-throw pupilloplasty, which is SFT. I don't have to put a knot there. Just the 4 throws goes and sits on the iris very comfortably. You can see that multiple times I'm doing that, making sure the pupil is there. I'm making sure the Purkinje images are centered right in the center of the pupil as well, and trying to reduce the size of the pupil as well. So you can see that at the end of the surgery, the pupil is very nicely centered to a certain extent, which is not round, but it is to a certain extent small as well. The hydrodialysis also became very, very small because of the pupil thing, because the iris was a little fragile there. I didn't want to handle that iris, and because of the infranasal, I left the patient again. And because the patient had a macular scar, the patient vision improved from, of course, 3/60 to 6/18 parts parts. So these are the two cases I wanted to show you just to give an opinion about the two different ways. There are many ways to skin the cat as far as subluxated cataract is concerned. The plan is to have a plan A, plan B, plan C for all these patients. And thank you very much for the wonderful opportunity, the patient attention as well.
Thank you, Mohan.
Stop sharing.
Nice presentations. Do we still have time, Dr. Alia?
Yes.
I think you should move on to the conclusion and the take-home message for the session. As for the question and answer, it can be done through the column, the Q&A column on the Zoom platform.
Okay, please, the speakers directly answer from the Q&A. And for the take-home message, can you, Mohan, for these sessions?
I think the take-home messages are very, very clear. All the speakers did wonderfully well. The message is very important, especially when you have a corneal tear, when you want to have do the cataract simultaneously or leave the cataract for a secondary stage. It is for the surgeon, individual surgeon, whatever is comfortable can do that as well. Number one. Number two, the second case showed that the staged approach is very, 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 very important. Taking care of the anterior segment and then taking care of the posterior segment and then taking care of the secondary IOL implantation. The only thing I would have done differently, because the iris is already traumatized in that particular patient, I wouldn't have done an iris fixation lens. I would have done a glued IOL, a scale fixation lens. But the results have been ultimately very, very good. And of course, the fisherman's knot, which is also very good way of iris repair, because the pupilloplasty is one of the major indications for surgery nowadays, because the patient we take care of the contrast of the contrast vision, the quality of vision as well. The visual acuity also improves to a great extent. I think pupilloplasty, we should know how to do it, and there are different ways of doing it. And Dr. John just has shown us a very nice way. And I have shown you different ways of managing a subluxated cataract as well. Overall, it's been a fantastic session, and I'm looking forward to a great webinar as well in the future, in the next sessions as well. Thank you.
Thank you. So, giving back to Dr. Alia then.
Thank you so much, Dr. Johan and Dr. Mohan. We have come to the end of the second session. And before we proceed to the third session, the posterior segment trauma session, we'll take a quick 2-minute breather to see a special message from our sponsor tonight. So, and for all the panelists, please turn on your camera, and here's a quick video for all of you to enjoy. Okay, thank you so much for the committee for showing us that. And we now We will now proceed to the third session, the posterior segment trauma, which will be moderated by Professor Caroline Chi from National University Hospital, Singapore, who needs no further introduction. She is one of the founding members of the APOTS Society. To Professor Caroline Chi, please, the session is yours.
Thank you very much. I think without further ado, it gives me great pleasure to introduce our first speaker, Dr. Gita Lisa Adriano, who is a well-known vitreoretinal surgeon from our host, the Jakarta Eye Center, and also in the Department of Ophthalmology of the University of Indonesia. She is going to show us a video on retinal detachment after blunt trauma. Dr. Gita Lisa. We also will be, the second speaker of our session who I'll have the privilege of introducing is Dr. Ryan Chang, who is the Chief of the Division of General Ophthalmology in the Taichung Veterans General Hospital, and is also the Director of the Department of Ophthalmology of the Tsinghua Hospital in Taiwan. And he will be showing us endoscope-assisted vitrectomy and ocular injury. So we will now have our first speaker, Dr. Gita Lisa. Would you like to show us your...
Yes.
Thank you.
Can you see my slide now?
Yes.
Thank you. Okay. Thank you congratulations to APOTS and also Jakarta Eye Center, and it's an honor for me to be speaking among these all excellent speakers. So I'm going to my case of choroidal rupture, retinal detachment, and vitreous hemorrhage. A female, 83-year-old. She is a retired literature lecturer. She had left eye injury after falling on. She was traveling abroad to Korea. She had blur of vision of her left eye after 4 days of the accident.
Excuse me,
Yeah.
can you put it on the slideshow? Thanks. Carry on.
Okay. Is it okay? Now, and she has a history of primary open-angle glaucoma and under anti-glaucoma eye drops, and also had cataract surgery of both eyes 3 years ago. So on presentation, her right eye vision was 6/6, while her left eye vision, which had the accident, was hand movement. IOPs of both eyes were within normal limits. And I observed on examination that day that she had eyelid hematoma, subconjunctival hemorrhage, clear cornea, deep anterior chamber. Fortunately, no hyphema was present, and the PCIOL was in good position. However, I cannot view the retina because of vitreous hemorrhage. So this is the left eye posterior segment ultrasound that I took that day. So we can see here in the vitreous cavity, there's diffuse vitreous opacity, hyperreflectivity here. And in the inferior part of the retina, we see a shallow retinal detachment. So I diagnosed this patient with left eye retinal detachment with vitreous hemorrhage due to blunt ocular trauma. The surgery itself was done a little bit postponed, so it was done 3 weeks after she presented to me. So I did a left eye 23 gauge pars plana vitrectomy with endo laser and silicone oil. So let me show the video. So after putting a 3-port, I addressed the vitreous hemorrhage first. You can see here, and we could see that inferior nasal part, there's a subretinal hemorrhage, and this is a choroidal rupture there. And there's inferior retinal detachment. The retinal break itself was difficult to identify, so I made a retinotomy in the inferior temporal and did a fluid air exchange until the retina attached. Then I saw suspected the area of, and I continue with putting a 1300 centistoke silicone oil injection. And I put the patient in a prone position for 2 weeks. So on follow-up, the left eye best reconnected again, sorry. Yes, can you see my slide now? Okay, so the IOP was stable. The retinal hemorrhage was also mostly absorbed. And after 5 months, we did the silicone oil removal on February 2019. And afterwards, I saw significant PCO, so an NDEC laser capsulotomy was done 2 months after the silicone oil removal. And this is the condition 1 year post-operative. The right eye was normal, and here we can see the left eye. The media is clear, the retina is attached, and I'm sorry, this is not a wide field photo, but we could see the laser scars in the inferior nasal part. And the left eye vision was 6/10. The patient was quite satisfied. I think I didn't see her afterwards. So for the discussion, ocular blunt trauma usually is caused by sports-related causes, household accidents, industrial accidents, or assault, and mostly in younger males. The retina effects of blunt trauma may include commotio retinae or Berlin's edema, choroidal rupture, which is quite well known, occurring in 5 to 10% of cases. Then we have vitreous hemorrhage, retinal tears, retinal detachment, which is a quite common complication, accounting to 10 to 20%, shown by a previous speaker, Dr. Elviosa. And also, I think this case rather show because it's relatively common, happening in an elderly patient, aware of the high risk of falling in elderly population. And they still want to remain active, go traveling, and so we must be aware. And the choroidal rupture is at the peripheral area, not occurring at posterior pole. And the literature mentioned that PPV with tamponade as a primary surgical technique was preferred as the primary, as the primary approach. And because of the complexity of the case, because this patient had RD and also vitreous hemorrhage and turns toward rupture, and almost 40% need retinotomies to attach the retina.
We've kind of got to get to
Roche, I think we're losing Dr. Gita Lisa here. We can proceed to the next speaker if you like.
Okay, so let's Dr. Ryan Chang, who will be talking to us, will be showing us an endoscope nephrectomy in ocular injury.
Excuse me, Dr. Alia, can you hear me now?
Yeah, we can hear you now, Dr. Gita.
Can I proceed? Just I think just the ending. I'm sorry for the bad connection. Can you see the slide?
Oh,
yeah, we can see the slide.
Okay, let's just finish up the
okay. Yes, I will. So I think in my case, we did the surgery in a rather late approach. Onset, but it is there's an advantage of the if we do it early. There's high risk of postoperative complications. In our surgery, in our case, the surgery was done after 30 days and brought relatively good outcome. And I think for the learning pearls, blunt trauma can result in various manifestations in the posterior segment that may be vision threatening. Careful evaluation, early recognition, timely appropriate follow-up are needed to ensure favorable outcome. And the correct diagnosis cured by media opacity. And each case requires individualized approach, and the prognosis is related to severity of injury of its complications. I think that is all. Thank you, and I'm sorry for the bad connection. And someday we will meet again in a real life seminar or congress. Thank you very much.
Thank you very much, Dr. Gita Lisa. We can have some questions at the end if we have time. Right. So now I have the privilege again of introducing Dr. Ryan Cha. You can begin your screen sharing.
Okay. Now, hi everyone. Can you see my screen now?
Yes.
Okay. Now, I'm honored to be here to share my case. I have only one case to share. This is a case with traumatized corneal blood staining. I use endoscope to assist the vitrectomy. I have no financial conflict disclosure. This is a 35-year-old male suffered from eye injury when he was working. And I was referred because the cornea of that patient showed corneal blood staining, but the B-scan in previous hospital suspect a posterior segment injury. The presenting visual acuity was bad perception, and indeed there was the corneal blood staining, and in B-scan I cannot draw a retinal detachment. So because of corneal blood staining, so I planned to use endoscope to assist the vitrectomy. My endoscope system is Endo-Optic E4. Before I start the video, you must have noticed that the image quality was not so good. It's not so good because that's the limitation of endoscope. So when you see the video, you will notice that the resolution of endoscope are not so good, even at this moment. We can see that there was a blood staining of cornea. And after we get enter into the eyeball, the first step is to remove the vitreous to a co-vitrectomy. The vitreous in eyeball under endoscope view. The background is quite dark, but the reflection of light of the probe, the retractor, is really strong. And then we can do the peripheral vitrectomy. Even we can do the vitrectomy to the vitreous space to the oral cell type. And at the same time, we can also check the area to even to retro iris area. After we remove completely the vitreous to the vitreous space, then I started to approach the epiretinal blood clot. It's impossible to have a bimanual technique because you always have to use one hand to hold the endoscope. So we only have one hand to operate. Be very carefully to remove the blood clot stick. It's really sticky and attached to the retinal surface. The endoscope view is quite blurred because of the some blood floating. I trim the blood clot slowly and carefully. You should keep your endoscope probe really close to the retina because you cannot really know the distance between your retractor and the retina. That's not a 3D view, that's a 2D view. So if you keep your endoscope too far to the retina, then you will lose the, you will not know the real distance between your instrument and retina. And so be really careful to remove the blood clot quite slowly. Okay. And then after you remove all the retinal blood clot, we can also do gas fluid exchange if the patient have retina detached or some retina breaks. So now I perform a gas fluid exchange. You can see the light reflex from the water surface. And there are some subretinal hemorrhage, and also there are some hematoma. But the retina can be reattached after all these procedures. The patient was so lucky that the subretinal hemorrhage just not involve the central macula. The subretinal hemorrhage did not involve the fovea area. So I do a complete gas fluid change.
Apologies, Dr. Ryan, I think the time.
Okay.
I almost finished my video.
Sure.
And be careful to the complication that's ultragenic retina break, because you do not know the distance between your probe and the retina. So sometimes we cause ultragenic retina breaks. Okay. My video is finished. So that's my presentation today. I show everyone an endoscope assisted vitrectomy. The key point I think is to be really careful to the distance. That means you should keep your endoscope probe to really close to what the area you want to operate. Thank you, everyone.
Thank you very much, Dr. Chang. If I could just ask you, this is obviously quite a steep learning curve. How many cases did you do before you became confident of doing this?
Before I perform endoscope vitrectomy, I do some animal eye training for months, and then but I think if you ask me how long a training time I can get comfortable, I think maybe it takes 2 or 3 years. Then you because at the beginning of the 2 or 3 years, I always cannot sleep well before I have a case. Yeah.
Okay. And have you tried using a temporary keratoprosthesis for these patients who have got cloudy corneas? Well, not so much.
Yeah. I did not do the temporary keratoprosthesis myself, but I have a cornea man to help me do that. But sometimes I do not. The reason why I keep using endoscope is because it can check the really peripheral retina, and the other reason is the time, and also the wound. Because the wound of this surgery is only 19 gauge, but if you do a keratoprosthesis, it will be a 60 degree wound. So that's why.
Thank you very much.
Thank
you very much. And thank you, Dr. Gita Lisa, for your wonderful presentation as well.
Sorry for the connection.
No problem. So we can close this session now, and the next session will be on intraocular foreign bodies.
Okay, thank you, Professor Caroline Chi, for the very interesting session. We will now proceed to the 4th session titled Intraocular Foreign Body, which will be moderated by Dr. Tengku Ain Kamalden. She is a future retinal surgeon from University of Malaya, Malaysia. And She's currently the associate professor at the University Malaya Medical Center. So, Dr. Tengku Ain, please, the session is yours.
Thank you very much, Dr. Alia. Assalamualaikum and good evening, everyone. Thank you to the organizers for inviting me to moderate this wonderful session. I have the privilege of introducing two fellow vitreoretinal colleagues who are prominent surgeons in themselves to share their experiences and teaching us their pearls in overcoming challenges in managing intraocular foreign body. So the first would be Dr. Referano Agustiawan, fellow vitreoretinal consultant and cataract consultant at the Jakarta Eye Center Eye Hospital, and who will be speaking to us about his experience in extreme fishing. I'm looking forward to that. And the second speaker is Dr. Hussein Kakan, who will be sharing with us his tricks and techniques of getting fishing out the intraocular foreign body. He is a vitreoretinal consultant, a very prominent surgeon who's come out with many wonderful videos from Pakistan, Lahore, Pakistan. I leave for Dr. Referano to present. If you could share your screen.
Thank you, Dr. Tengku Ain. Yes, Assalamualaikum warahmatullahi wabarakatuh. Good morning, good evening, and good afternoon, wherever you are. I want to share my case. It's actually 4 cases about the intraocular foreign bodies. Slide. Actually, there is no, like fishing, there is no clear-cut technique to remove intraocular foreign bodies. It depends on velocity, it depends on how big the foreign body is. So I want to share my case with several different approach. This is the first case, male 26 years old with accidents with metal during work with visual acuity is only 1 meter finger counting with traumatic cataract. And actually I couldn't make sure the exact location of the foreign body from the B scan according to low quality. So I decided to do vitrectomy and phaco to find the foreign bodies, right? And this is the video. So this is the port, entry port is in the limbus, superior limbus. So I did the phaco and found there is a floating foreign bodies in under vitreous and in the sulcus. You can see here. Just quite big foreign bodies. So it's not seen in the B scan because it's very anterior. So I continued to do vitrectomy, and I couldn't find any more foreign bodies in the vitreous. I put the triamcinolone to see the vitreous clearly to make a PVD, and put the lens, okay, and put silicone oil inside. Slide. And this is 6 months after surgery. The visual acuity is 6.6. Slide. In other case, there's a male 40 years old hit by a piece of metal. Visual acuity is quite good, 0.3 with corneal laceration and traumatic cataract. So I plan to do corneal rupture repair with phaco and vitrectomy and removal of foreign bodies. Slide. We can see here from the fundus photo, there is a retinal breaks just near the macula because of foreign bodies, and the foreign bodies in the temporal inferior of the macula. Slide. This is the video. So first I suture the cornea to make airtight condition so I can do phaco and vitrectomy more easily. You can see that there is a thick blood in the vitreous and quite big foreign bodies, metal, and it looks like it hit the retina before it placed there. So I plan to remove the foreign body from the sclera with X incision in the sclera. see, and laser, Barrett's laser in the retinal brick. Slide, and put the silicone oil inside. The visual acuity is 0.1 after surgery. It's less than before, but it's quite good for traumatic eyes. Slide. So this is the third case, male with history hit by nail. Visual acuity was 0.2 with corneal scar due to epithelialized corneal rupture with traumatic cataract, vitreous hemorrhage, and intraocular foreign bodies from the B scan. Slide. So this is the surgery. We can see here the corneal rupture already epithelialized, and just did the phaco. You can see here the hole in the iris due to high velocity of the foreign bodies. The foreign body is actually floating in the posterior vitreous. So I decided to remove it from the anterior chamber because it's quite small. I grab with forceps and take it with my right hand with pincet. See. So I put a lens afterward. Just keep in mind if you want to remove the intraocular from foreign bodies from the anterior chamber, just don't put IOL after the phaco. Just do it after the removal of foreign bodies. I'll always do laser 360 degrees to avoid retinal detachment afterward. Okay, this is after surgery slide. After surgery, vision is 0.7. It's quite good. And the last case, the patient sent to me with a history of hit by a piece of plate 5 days back. The visual acuity is 0.6 with epithelialized corneal rupture, but there is no significant cataract, and the retina is attached. So I plan to do vitrectomy, extraction of foreign bodies, and silicone oil tamponade. Slide. Okay, this is the surgery. I can see the foreign bodies in the inferior of the retina. It's stick there. So first I do vitrectomy and Barrett's laser around the brick caused by the foreign bodies, and then remove the foreign bodies with forceps. This is can happen to anyone. When I grab the foreign bodies, the scleral tunnel is not enough, so I lose the grab. So the foreign bodies fell down to the retina and cause bleeding. It's some accident that you have to avoid, and I clean the bleed and laser all the bleeding source, and laser and put the IOL inside. And even though the visual acuity is worse than before, right? But the patient have to back to his hometown in another island, so I cannot see how his condition right now. So from this cases, we can conclude that there is no clear-cut technique to remove the silicone, to remove the foreign bodies, and sometimes the prognosis is good, but sometimes we have to prepare for the worst case. So it's the prognosis of our IOFB removal can be highly variable, but it is often favorable with the timely surgical attention. Thank you. Right.
Thank you very much.
Thank you for Dr. Kartika for editing my videos.
Thank you very much, Dr. Referan. Those are very good videos and learning points as well. I would like to invite Dr. Hussein Khan next to share your screen.
Yes, I am here.
Yes.
Yeah, sure. Can you see, please?
Yes, we can see
Hello?
your screen. Yes. Hello?
Can you hear me clearly?
Yes.
Hello?
We can hear you.
Can you hear me?
Clear and loud.
Yes.
Okay. Okay, thank you so much. So my presentation is about the intraocular foreign body. My previous colleague has already described few tricks. So I will be very quick. My presentation includes 7 videos where you will see the different techniques of removing different types of foreign bodies. I have exact 5 minutes video, so that's I am starting it here. I have no financial interest for showing any surgical video or any technique. My case 1 is a patient has corneal tear. It has been repaired at the primary care center here on the CT. You can.
We lost you there. Prof. Hussein? Oh, I'm sorry. I think we lost you there. Would you like to share your screen again, Prof?
And I mean, why don't you move on to the next presentation, and then when he's ready, he can come back.
Okay, I think for intraocular foreign bodies, we only have 2 presenters. So
yeah, we only have 2 presenters.
Yeah.
Oh, I see. So why don't you lead a question and answer session until he's ready?
Okay. So, Dr. Farhan, I'll start off with the question. What's your decision on the choice of tamponade that you choose when you approach the foreign bodies?
I usually use silicone oil if I saw the retina is not in good condition, because in the traumatic cases usually there is so many RPE that can cause severe PVR. I think Dr. Hussein Kakan is already there.
Yes, I am here. Right? Yes.
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 All right. Thank you.
Can you share screen? Yeah.
Yes. Just a second, please.
Rafrano, you can continue answering.
Yes. But if the effect of the foreign body is not affect retina too much, so I just put the gas instead of silicone oil.
Okay. Thank you. So meanwhile, I'll just like to remind if the presenters, if there are any questions and answers sessions, you can from the audience, you can reply them directly on the Q&A column.
So I'm sharing my screen. Can you see my screen?
Yes, we can, Prof.
Yes, please. So I'm showing you the first case. Here you can see the corneal scar, and patient has a cataracted lens. So first the lens matter aspiration in this case was done. Here you can see I am doing 23 gauge pars plana vitrectomy and removing the vitreous hemorrhage. So at this point you can see a large intraocular foreign body that is at the inferior retina and anterior retina. You can see the size of the intraocular foreign body, and it was aphakic eye and there was deficient posterior capsule, so I removed it from corneal limbus. You can see the huge size of this intraocular foreign body. These are the post-op images of this case. So now I'm sharing the second case. The similar condition, almost the large intraocular foreign body. Here it has a diffuse vitreous hemorrhage. Here you can see, but the difference here is the foreign body is very large and deeply embedded in the retina and choroid. First, I have to entangle it from the retina and choroid. Then with the end grasping forceps, I have to dislodge it from the retina and choroid. And you can see the size of intraocular foreign body. It's so huge. As it was a pseudophakic eye, so I removed it from the pars plana side. So that's another case. I am coming from the large foreign body to the small foreign body. This is relatively a small foreign body, but it is deeply embedded inside the retina and choroid. So I did endo laser, and then you can see I had to remove it from deep in the choroid. It's relatively a small foreign body. The trick here is that it has been hidden under the retina and its choroid. So I am removing it from the pars plana. And these are the post-op images. The retina is flat and the vision improved. So here I come with another case. This is aphakic eye, but the difference here is that you can see the intraocular large foreign body. It is lying under the retina, and retina is totally detached. So what I have to do to remove it from underside the retina? So I displaced the subretinal metallic foreign body from macula with a soft tip extrusion needle, and did the retinectomy in the supranasal area. So from the retinectomy, I will remove this subretinal intraocular foreign body in this detached retina. You see with the soft tip extrusion needle, I am moving this foreign body to the retinectomy area. So with the clasp forceps, intraocular foreign body forceps, and with the help of light, I am removing this large intraocular foreign body from subretinal space. So you can see the huge size of intraocular foreign body. It has been displaced in the subretinal space, and it is a aphakic eye, so I am removing it from the limbal wound. Next, my fifth case. This is a cataractous eye post-traumatic corneal tear repair done at the other center. Again, lens matter aspiration removal. Here, the trick is that while doing the vitreous clearance, you can see the foreign body was lying in the vitreous. As I cleared the vitreous hemorrhage, then it fell down on the macular area and it traumatized the macular area. So it's always wise to keep an eye on the foreign body while doing clearing the vitreous hemorrhage. So this is also an intraocular foreign body case. Here you can see hemorrhage is resolving phase and it is not as much dense. The trick here is that I am holding this foreign body with the clasp forceps. But as I tried to remove it, it slipped away from my forceps and fell down over the retina. But in this clasp forceps, I have a magnet. So with the magnet, I am just touching the foreign body and lifting it, not holding it, and putting it over the hemorrhage. And then again, I am grasping it with the magnet clasp forceps. So this is just a trick. If it falls down, if you have magnet forceps, then you can easily lift it up and remove it so easily. So this is just a very simple case, just for a lesson. This is foreign body is very small and it's lying in the mid-vitreous cavity. I prevented it to fall down on the retina, but oops, when I tried to remove it, it lost at the pars plana 23 gauge port. So the trick here is that you then have to indent it, and I found it at the pars plana area. So with the indentation, I found it, and it's not always lucky to find it in the anterior space. So I just found it over there and displaced it with the light and grasping forceps in the mid-vitreous cavity. And then at the end, I was successful to remove it. Thank you so much for your kind attention. If you have any questions, I am here and my email is there. I was a little bit quick because I was given 5 minutes time. Hope I tried to convey my message through my 7 videos. Thank you so much.
Thank you very much, Prof. That was really enlightening. Thank you, both speakers. I'd just like to summarize the points from both presentations. I think managing intraocular foreign body is an acid test for most surgeons and for a VR surgeon when it hits the posterior segments. And it can be from something is easily visible to something hidden, and from something simple to something technically challenged. And I think at all times, we might agree that we anticipate and prepare for all the possible intraoperative complications, and always be ready to improvise our techniques. So with that, I'll leave the floor back to Dr. Alia.
Thank you so much, Dr. Tengku Ain. So that was a very interesting session, the intraocular foreign body session. So we will now proceed to our last session of today's webinar. So please, for all participants, bear with us. This is the very last session with the topic of visual rehabilitation after trauma. This is a very interesting session, and it will be moderated by Mrs. Annette Hoskyn from the Lions Eye Institute, Sydney, Australia. She has done quite a very good job in the field of visual rehabilitation after ophthalmic trauma. To Ms. Hoskyn, please, the floor is yours.
Thanks so much, Dr. Alia, and let me say how very pleased I am to help moderate this very last session. I think we've saved the best till last. We have Tri Rahaya from our host, the Jakarta Eye Centre. She's a cataract and refractive surgeon who also has lots of knowledge and understanding relating to contact lenses, and she's going to be presenting on scleral contact lenses for post-traumatic eyes. And we also have Daniel Bohan from Singapore, National University Singapore. He's a specialist in low vision and rehabilitation. And he's got a very interesting topic of lens on the loose, visual rehabilitation for a subluxated lens. I'm going to hand straight over to Tri to speak on cataract and refractive surgery, scleral contact lenses. Thanks so much.
Thank you, Ms. Annette. Because I'm from Bali, it is a remote area, so I already have pre-recorded video for my presentation. So please, the IT team, play my presentation video. Assalamualaikum warahmatullahi wabarakatuh. Today I will present my topic with the title Scleral Contact Lens for Post-Traumatic Eye. Traumatic ocular injury can significantly reduce patient ability to function. The symptoms may be vary from mildly irritating to visual debilitating. Visual outcome following repair of post-traumatic penetrating corneal injury may not be optimal due to presence of irregular keratometric astigmatism. Eye injury caused by chemical or burns can lead to significant damage to the corneal surface, resulting in scarring, astigmatism, discomfort or pain, and visual distortion. Scleral contact lens have play role in a traumatic eye. In post-repair corneal penetrating injury, scleral contact lens can mask significant amount of irregular astigmatism and can improve the vision. In post-chemical eye injury, scleral contact lens help provide clearer vision while also hydrating the eye, protecting it from further harm or irritation, and allowing it to heal as best as possible. The design of scleral contact lens contains of optical zone, transition zone, and the landing zone. Fitting step in scleral contact lens, we must evaluate the diameter, clearance, landing zone fit, lens edge, and non-rotationally symmetrical design. For the diameter, total diameter of the contact lens have most basic consideration. Large contact lens give more fluid reservoir. It is a benefit for fragile corneal epithelium and tend to decenter temporarily. Small contact lens more stable and it form more than normally shaped the cornea. Optical clearance diameter give good optical outcome. Usually it is 0.2 mm larger than corneal diameter. For evaluating the clearance, the corneal clearance should be 200 to 300 micron, considered sufficient. And also we must evaluate the limbal clearance. Landing zone, closely related to the clearance. The goal of this landing zone is create alignment with the scleral or corneal scleral transition. Evaluation can be performed by slit lamp evaluation with fluorescent evaluation and also with the anterior segment OCT technique. The lens edge make the good edge lift promote healthy lens wear, but too much edge lift causes lens awareness and discomfort, and low edge lift can leave a full or partial impingement of ring on the cornea. Movement must be evaluated. Typically, scleral contact lens do not move. Push-up test should be reasonably mobile, and vertical movement, it doesn't increase the circulation, so we must evaluate it. After we choose the best diameter and base curve of the contact lens, then we perform over-refraction. Lens power should not be main consideration during lens fit, but creating optimal lens fit is the first most important objective. Insertion and removal of the scleral contact lens also challenging to the patient and also us as a provider. But because it is different with the conventional RGP. This is our two cases. The first case is a 48-year-old female with corneal scar and aphakia of the left eye after penetrating injury. So after the surgery, the vision of the left eye became 1 meter finger counting with plus 14 diopter of spherical lens. It could be reached 0.4 only. With the scleral contact lens, we use Jupiter here, the visual acuity could be reached 1.0 or 20/20 vision. And this is the second case. It is 48-year-old male with the severe chemical injury of both eyes. The left eye only have hand movement vision, even though it is already performed keratoprosthesis. The right eye have scarred cornea and neovascularization cornea. The vision can be reached 0.15 with the severe dry eyes. Jupiter contact lens, scleral contact lens can give 0.4 vision. It is increased from the spectacle correction, and also give the improvement in dry eye symptoms. This is the anterior segment OCT for the second case. The scleral contact lens give central clearance of about 300 micron. It is considered enough, and also have about 100 micron of the temporal and nasal left edge. So as the conclusion, scleral contact lens can improve the vision and comfort in post-traumatic eyes. However, its fitting still be challenging as us as a contact lens provider. Thank you.
Thank you very much, Dr. Rahayu, for a very enlightening presentation, and I think this really highlights the sort of difference you can make with visual rehabilitation, particularly for those patients with very little vision remaining, and any amount that they can gain is helpful. So with that, I'll hand over to Daniel. Thanks, Daniel.
Thank you, Annette, and good evening, everyone. So today I'll be sharing a case on how we approach and provide vision rehabilitation for subluxated lens, which can be a common impact of ophthalmic trauma, and somehow these patients we are not able to cure their sight, and we try our best to explore means and ways to make do in maximizing their remaining vision, and at the same time preserve their functioning and improve their quality of life. So this patient is a 50-year-old female that presented to us with sudden vision loss. She has high myopia and a history of blunt trauma to both eyes 5 years ago. And her presenting VA were 636 in both eyes and improving to 618 with pinhole. And covered tests showed intermittent XT. And on examination, we found a bilateral inferior lens subluxation, and she also had myopic maculopathy. Because of the complexity of this case, surgical intervention was not indicated. Then she was referred for further assessment and refraction. So we proceeded with retinoscopy for both the phakic and aphakic portion. So this is something that is unique presentation that we see in subluxated lens, where we see both the phakic and the aphakic portion. And this is where we need to carefully observe the two portions. And when we do retinoscopy, you know, it can be a bit tricky, but you know, it helps to recognize and identify the phakic portion and the phakic portion, and then perform the rets from there. So sometimes I would do what we call a peripheral retinoscopy, where I try to identify the reflex at the edge of the lens. So the phakic retinoscopy revealed a -13, whereas the aphakic retinoscopy revealed a +18. We proceeded with a manifest refraction, and the patient subjectively accepted a -12 on the right, that improved to 624, and accepted a -10.5 on the left, that improved to 624, and with a +2 add, is able to resolve an 8. And because there is no further improvement from here, she was referred further for vision rehab. So on the first visit at the low vision clinic, she complained of difficulty seeing signs ahead when she takes the bus or when she's trying to look at road signs, and also difficulty in reading newspaper. Presenting VA with the glasses is 630, 645, and near is N18. So we see a bit of troubling there, trying to read up close. We did a manifest refraction, and it revealed a -11 with -2 seal. X is 90, that brought her to 624 on the right, whereas on the left is -11 with -1.5 seal with X is 90, which brought her to 636. And we gave a +4, which is a default magnification factor. So +4 equates to +1, 1 times magnification, and from there she's able to resolve N5, which is smaller than newsprint. But subjectively, no further improvement in visual acuity. And how I like to qualitatively assess for visual improvement is I like to stand in front of the patient, maybe 3 to 4 meters in front, and use my face as a gauge, because that gives me a sense of contrast improvement. Because sometimes it doesn't show up, the VE doesn't show up, but the patient can appreciate an improvement in contrast. So I will stand in front of the patient 3 to 4 meters ahead, and then put on the new RX and see whether there is a difference in my face. And sometimes I like to use a clock that is hanging on the wall, and to see if the patient can tell the time. So that's a good gauge that there is a functional gain with the new prescription. And from there, I also explored a hand magnifier, that would improve a newspaper reading, and that allow her to read up to N5, okay, with a 4 times or equivalent to +16 diopter. And to address her impairment at distance, we explored a telescope, a simple handheld telescope, and that basically gained her vision to 6.9 with a 3 times 3 power telescope equivalent to +12. So the plan was to continue to wearing her glasses, but I also advise her on protective eyewear, preferably if she could put on a pair of sunglasses over, a fit over, or if she could consider getting polycarbonate lenses. And I prescribe a hand magnifier for sustained newspaper reading, and also telescope when she goes out and about to see road signs and street signs. And at 2-year follow-up, she came back again to the low vision service and complaining of declining vision with existing glasses. And this time her VA has dropped further to 660 on right and 645 on left, improving with pinhole to 618, which is a good sign. On examination, unfortunately, there was further inferior subluxation of the lens, and now we could see the visible lens age. And when I did the retinoscopy, now I could observe the aphakic portion, but somehow I couldn't appreciate the phakic portion. So somehow the lens have actually subluxed further. And then from there, we obtained a +8 with -2 seal that brought her to 618 on the right. On the left is +8 with -1.5 seal that brought her to 618. This was much better than 2 years ago. With a +4 add, it brought her to 6 and 8. And with her current low vision aids, it is optimal. She's reading N5, fluent with newsprint, and with her telescope, now she could see 6.6. Then I brought her outdoors because I wanted to observe the effect of meiosis. And this is important because in patients with subluxated lens, depending on where the phakic portion and the aphakic portion will be positioned with meiosis, it will have great and significant impact on vision. So when we went outdoors, there was no significant effect on her vision. So from there, we decided to update her glasses. Now, we prescribed her with aphakic glasses, okay, and she could see 618. And to continue her low vision aids, and at the same time, lifestyle advice to avoid high impact or contact spots, because it is important that we preserve her eyes and also her remaining vision. So the clinical pulse for this is to highlight the role of low vision and vision rehab in the care of patients with ophthalmic trauma. So these are the two main questions is to ask is how is the patient impacted by the vision loss? Because vision loss is highly subjective and no two patients experience vision loss similarly. So it's important to ask how are they doing, how are they coping in their day-to-day activities? Are they still reading and how are they reading? And also to ascertain the patient's visual goals. Is it more important for them to see near, to see intermediate like computer work, or to see far ahead? And in subluxated lens, it is important to to refract the patient undilated and try to appreciate and try to identify and observe both the phakic and aphakic portion and do retinoscopy. And then subsequently to proceed with subjective refraction, both indoor and outdoor, and see what works best for the patient. So sometimes phakic refraction works best. At the same, at other times, sometimes it's the aphakic portion that the patient accepts. So it's good to explore both findings and to go outdoors and see what's the effect. At the end of the day is to optimize residual vision as much as possible with accurate refraction and advice on protective eyewear. And also, if possible, to avoid engaging in high impact or contact spots. So these are some of the learning points that I've learned in managing this case. So that's my case. Thank you very much. And over to you, Annette.
Thank you so much, Daniel. And you've really hit some high points for me to close this session. And I'll hand it over to Alia in a second, but I just wanted to, based on both of those great talks, I just wanted to give you 3 takeaways. The first one being that these patients are going to be really motivated. So it's important to try and capture any vision or any additional comfort that we can for them at all. And secondly, it's not just refractive gains that they can get. It can also be about dealing with some of the symptoms that they may have in terms of dry eye or glare. And the last and very important one is about protective eyewear and ensuring that they're continuing to maintain as much vision as they can and protect whatever remaining vision that they have. So I'd like to again thank Daniel and Tree for their excellent presentations, and I'll hand over to Alia at this point.
Thank you, Annette, for the very wonderful conclusion of the last session of visual rehabilitation after trauma. A very important aspect that we sometimes forget on our patients. So we have now reached the end of this 4th APOTS webinar in conjunction with the JEC Eye Hospitals and Clinics. Very interesting cases that we had from all of the panelists, and what a response from all of the participants. We can see the high enthusiasm coming from all the participants, the panelists, and also the moderators. Thank you all for sticking with us until the very end. Unfortunately, due to the time constraint, we are unable to answer all the listed questions live, but most have been answered on the Q&A column, I see. And a quick announcement, I think the IT team can show us the poster. Yeah, so on the next September 5th and 6th, I think it's 2 weeks from now, there will be another virtual conference from this very society, the Asia Pacific Ophthalmic Trauma Society, presents the 5th APOTS virtual conference. So if you can all join us again in those conference, it will be really it will be our pleasure for you to join us all. And on behalf of the committee, I would like to thank all of the panelists, the moderators, and not to forget all the participants from all over the region that has made all this possible. Special thanks to the Asia Pacific Ophthalmic Trauma Society, and not to forget our generous sponsor, Chenda Pharmaceutical, for making this happen. And we hope to see you all soon in the next meeting. Thank you all and good night.